You're obviously on this webinar tonight because this is what you're interested in learning about, is electric dental anesthesia. And electric dental anesthesia has been around a long time, but this device has not been around a long time. So that's what we're super excited to learn about tonight, is these two new products that can help our practices and help our patients. So a little bit about myself. I'm a pediatric dentist, my husband is a general dentist, and we practice together. And we've been practicing together for almost 30 years now, and we are still married. I didn't say happily or unhappily, but we are still married. And these are our kids. We have 3 boys, Matthew, Luke, and John. And we have 2 dogs, Maverick and Goose, all Y chromosomes except for myself. I'm the queen. There's no princesses around. There's no DNA princesses around, put it that way. And this was our latest family. This is our latest family vacation, probably our last like close-knit family vacation. We went to South Africa this summer. We saw all the things. We saw the Big 5. We ate all the things. We just had a great time, you know, connecting as a family, but also unconnecting from social media and our cell phones, and just seeing nature and seeing what God has, you know, provided. So very good last family, hurrah, family trip, because now our family is growing. So this is Matthew. Matthew's 25. He works for HubSpot, and he and his now fiance are also models. And I have an updated photo of that coming up. This is Luke. Luke is our middle son. He's 23. He is a second-year dental student at MUSC. We call him the mayor. I think he's even on here tonight. Chris, do you see him on here?
Let me check. I don't know.
No CE for you, Luke, if you're not on here. He jumped on a New Smile webinar last week. He thought it was me speaking and it was somebody else. I'm like, you're a fool. Anyways, he's a second-year student. We call him the mayor at MUSC. He seems to know everybody and he's very involved, and we're very proud of him. And then this is John. John is a junior at Clemson, and he is an entrepreneur, and he wants to get into real estate and 10x everything. So this is Matthew and Maddie. This was actually 2 weeks ago. They were in the south of France, and they got engaged, and they modeled. She is a full-time model, and he models alongside of her sometimes for different fashion shoots. So that's one kid locked up now. And then we got a second kid locked up. That kid got locked up 2 months ago to Faith. That is his fiance now. I have to use this new vernacular. And they'll be getting married in about 1.5 years. And she's in school to be a nurse practitioner. So they're going to be just fine. And this is John and Sal. Sal and John have been together since 6th grade. And Sal is a junior at Queens, and she plays rugby. She's a little baddie. So when I say there's no females in the family, there really aren't, but these 3 are creeping in, and I love all of them. And one thing I can tell you, once you get to this age, is you can, you know, you can't pick the people that your kids pick for their people, but I am so thankful and fortunate that our kids have picked these women, because they're just awesome, strong, unneedy, undramatic, awesome human beings. And here's some other awesome human beings that we're going to talk about here. First of all, let's talk about my practice. This is Holly Tree Pediatric Dentistry. I practice with my husband, who is Bynum Aesthetic Dentistry. And then I also have this little side hustle, the Tot Spot, where I do airway evaluations and frenectomies on babies up to grandparents, actually. And I love doing this. I've been doing this for 12, 13, 14 years. And I would probably say this is one of the first things that really got me to step outside of my comfort zone and grow and take a risk and help people. And I would put these devices on that same level. This is something where I put myself outside of my comfort zone. I was an early adopter. I was one of the first people to try the device when it dropped over here. And I haven't looked back. And I feel the same way with doing frenectomies on my patients. So again, that's called the Tot Spot. Here's another awesome human. This is my business partner. This is Dr. Megan Churowski. She just went out on maternity leave. Yesterday was her last day of patient care. She's going to have her 3rd little one here at the end of the month. And she is we say she's like me 2.0. And Chris, am I allowed to say anything else about Megan at this point?
You absolutely can if you want.
So really, really super proud of Megan. Megan has made her own path in pediatric dentistry, not on my coattails at all. And she has caught the eye of New Smile, and she has a following of her own for her own age group and friends and colleagues. And she'll be working alongside New Smile as well, helping introduce new products and technologies and teach other pediatric dentists all the things that New Smile has in store for all of us. So super proud of her, really excited for her when she gets back from maternity leave to jump on the New Smile train with all of us. And again, we just can't do it without this amazing team behind us. We have an amazing practice, but it's not so much because we're amazing. It's all these women behind us that keep the wheel spinning. This is Dr. Maria. She is another person in our practice. She started 1.5 years ago. She's amazing. Her and Megan, I thought it was going to be just the three of us, the 3 female amigos, and we would, take the practice to the next level. And then we realized we were running out of space. So we decided to add on to the building. And as we were adding on to the building, we decided, gosh, we're going to need some more doctors. So we've now added Dr. Bassem Nashed. Bassem has started with us. He started with us this summer, actually. And this was him on the first day. So talk about instant immersion and fitting in and being in the right culture. And I think that is one thing that if you've ever heard me speak, I'm really big on culture. And this wasn't by accident that Bassem started with us and just fit in so perfectly. We did lots of vetting on the front end, lots and lots of communication to make sure we were going to fit. And that's kind of how I feel about New Smile as a company. I feel like it's the culture. It's who I want to buy my products from. It's the people I want to surround myself with. And then when you look at Bourbon and Baby Teeth and Restore courses and all these things that they do for us, it just takes it to a whole nother level. Like think of any other dental company. Well, there's not really a pedo specific one, but think of any other dental company that loves on us and embraces us and creates this culture for us like New Smile does. I mean, that was like, I just vomited New Smile on y'all, but that is truly how I feel about it. And this was when I was just a customer. I would look and be like, this is different. These people are just different. All right. So back on track tonight, we're going to talk about electric dental anesthesia. When I went to Bourbon and Baby Teeth 2 years ago, I really didn't even know what that meant. Actually, I really didn't care what that meant because it really didn't resonate with me. I was like, whatever that is, I'm never going to do that. I have like a normal syringe. My husband, being a general dentist, he'd had a wand, he'd had a Stabident. I mean, I kind of knew it was something like that. And I was like, I mean, all I do is hear him complain about those things. And the wands sat on the shelf and discolored, and finally he got rid of them. So I was like, this really isn't anything for me. And then I ended up getting thrown into the lecture to hear Dr. Prince speak, and it completely changed my thought process. And it was definitely like a God wink that I even chose to walk into that lecture, because I was being pulled to go on a bourbon tour at the same time, and I made a better decision. So one of the things that I think is the first question that everyone wants to know is like, how do these devices work? Like, what is so special about them? What does set them apart from these other devices that many, or maybe some of us have heard about in the past? And the coolest thing about it is we are bypassing everything. We are going straight through, down to the apex, down to the nerve, and numbing the tooth. We are bypassing all the soft tissue. We're not making a bolus in the soft tissue. We're not guessing whether we've got profound anesthesia or not. We are going straight to the source, which is the nerve, which is sitting at the apex of the tooth. And that is the target. The target is the apex. So that is what we're aiming for. Because then we don't, then we're not just like shooting in the dark. And you've heard me say this before, will hear me tonight. Stanley Malamed says that once the needle pierces the tissue, we're all giving a blind injection. Every single one of us is giving a blind injection. And the beauty of giving an injection this way is once you hit the bone, you're not so blind anymore. You're not just floating around in soft tissue, pressing on your syringe to deliver anesthesia. When you're in the bone, you're in the bone. And when you're giving a manual injection, this is what I come across all the time. Well, I give a great injection. Well, you know what, people, I give a great injection too. I've given a great injection for 25 years. I don't just like push anesthesia in kids and hurt them. I think we all pride ourselves on being gentle and delivering excellent care to our patients. But even when we think we're going at a steady rate, we are human and our hand is not injecting at a steady rate. And every time that we push on that plunger and we're not giving it at the right rate, that's when the discomfort comes, because that's when all that acid builds up in the tissue and it freaking hurts. And when we use a device like the Soan or the Sleeper that we're going to talk about today, it is truly controlled for us. Once we put our foot on that foot pedal, we don't have to question the speed or the cadence that the anesthetic is being delivered to the patient. So that's one of the first benefits of it. So the benefits that they provide to the patient, obviously way more comfortable, but this is a huge benefit. And this is the benefit to us as well, right? This is, I mean, this kid on the bottom that needs braces, this is my patient. And this is, and the kid played on my kid's baseball team. And the mom is like literally sending me the pictures, flipping out and wanting to go to the emergency room. How many times do we see this? They want to go to the emergency room. Then the emergency room wants to tell them that they're allergic to Novocaine, which isn't even a thing. Like, we don't have Novocaine, whatever. It's just, it's a mess. So if we can prevent us having to clean it up on the back end, and can prevent a parent being upset and a kid being, in discomfort, boy, that's a win-win for everybody right there. So there is no collateral numbness when you use these devices. It does not numb the tissue.
Dangerous.
Dangerous.
Smoothie.
Making smoothie.
Calendar.
No meetings today. Remember, tandläkare at 9:30.
Fire off.
Fire off.
Open door.
Door open. Så ska vi sätta en till.
Fire. Open door.
Run voice command.
Open door.
Run voice command.
Open. Open door.
Repeat back.
Open door.
I didn't understand that.
Open door.
Play on the floor.
Get on the floor. Open the door. Here you go. With a rock. Open door.
Fire, really.
Fire.
I watch this. Obviously, I play this every time because I just feel, I mean, if you've seen these webinars before, you've seen it before, but I've seen it probably more than any of you, and I still laugh about it. But I also think, like, boy, if we could have one less reason for the, society to make fun of us and for us to be the butt of jokes, that sure would be nice as well. So, this no longer will be happening with these devices. So mineral discomfort, if any, leads to a happy patient. And I'm just going to drop this in on you right here, right now. I'm going to encourage you to practice on your friends, your colleagues, your team members, co-residents, whoever, family members, whatever. And you need to know, and you need to let them know that they are probably going to be a little uncomfortable because you are learning. You are on a learning curve. You're not just going to go in the first time, nail it, get it in there and go. So you're going to be messing around. You're going to be, teasing it and pulling it back out and poking around a little bit. So yes, will your first set of patients probably have some discomfort? They will. Think about your first set of patients when you were delivering, traditional anesthesia. So, you're never going to see New Smile put anything out there that says 0 discomfort, 0 this, never this, always that. That's a slippery slope and they're not going to ride that. So I want to make sure that I say that, when you're practicing, you're probably, there's going to be a learning curve here for all of you. So less fear of needles and a syringe, because these devices do not look anything like a traditional, vaccine they would get at the pediatrician or something that they would get in our dental office. You know, that's what we're always trying to hide, that damn thing, even from grown adults. So what benefits do they provide to the dentist? This is a big one right here. Of all the things we do in a day, over and over again, day after day, week after week, month to year, decades, this motion of back and forth and the tension that we put on our hand and this muscle in our hand, this can be the thing that takes us out of dentistry faster than anything. So knowing that you no longer have to give those injections that can be detrimental to your career is a huge benefit, I feel like. And the Soan and the SleeperOne, this is the Soan right here. You're literally holding it like a pen. Very easy. You know, you don't have to have a tight grip on it at all. And the other biggest benefit, the collateral numbness, I feel is the giant benefit. And the second giant benefit is the patient is numb immediately. And that is a benefit to the patient and to us as well, right? For many, many reasons. This allows you to have more efficient treatment planning, right? You're not worried about collateral numbness bilaterally. You can, you know, you can get more dentistry done. You don't have to worry about a kid chewing up their face. So you can like treatment plan and be strategic in what you're doing. A less anxious patient is always a less anxious dentist, right? You know, when you go in with the Q-tip to put topical on and the kid's already being a fool, or they're a fool before they even get in the chair, right? That raises our blood pressure level too. And we know like this isn't going to be the smoothest situation. And then, you know, and sadly at the end of all that is a parent ready to write a 1-star review, right? So, you know, we're worried about the kid, but we're also worried about, you know, the perceptions from the parents as well. This is our practice, my practice. And what I want you to appreciate here is that's a window. It's a two-way window. We can see out of it. The parents can see in it. You can just see the head of the parent. She doesn't care. She's sitting down on the bench that's back there looking at her phone or reading or something. She's not concerned at all. But some parents are like glued to that window, right? Like a hawk. They're watching everything we're doing. And this is just a great, we don't have parents in the treatment rooms with us. They can either sit in the reception room or they can be out there. But this is just a great example showing you how unanxious dentistry can be for patients and families. Right? I mean, given the shot is like the worst part right there. And here the kids already like having the dance off. Which is super cool. So where has this been all my life? Like, why are we just now hearing about this? Why does New Smile have it? What exactly is going on? So I'm going to kind of give you the background story here. We'll cruise this kind of quick, but it started with this company called Dental High Tech. They have 26 years of experience in doing research on dental anesthesia, millions of injections. It's in over 30 countries. It's in the hands of over 10,000 practitioners and growing. And it's lectured about. Intraosseous anesthesia delivered with these devices has been lectured about for years. And there's over 3,000 courses and growing around the world. And these are the stars right here. These 5 men at the top, they live in different countries and they have trained everybody down below in the ladder of leadership to teach in these other countries where these other flags are. And the reason that it hasn't been in the United States is that we have the FDA and they are super difficult hoops to jump through. Chris is smiling as I say this because his blood pressure is going up as I say it. And, you know, sometimes when there's something great to come to the United States, people just say F it and they don't do it because it costs a lot of money. It costs a lot of time. It may not get approval. And, you know, that is one thing, being behind the curtain and watching this take place. They have worked so hard to get this product in the hands of Americans. It is in the hands of all these other countries and has been for years. But for good reason, we have the FDA, you know, to prevent like bad things from coming in. But, you know, this was a good thing and they worked really, really hard to get it here. And then myself and Larry Johnson are the two who are kind of, you know, taking the baton and running with it. The top 5 men above are the ones, a few of those are the ones who have trained us, so that we can then start teaching you how to do it. And then hopefully some of you are going to become amazing at it as well, and can start teaching other people as well, because this isn't something that Lori and I can do and plan to do forever, because it's going to continually grow and get in the hands of more and more people. These are the countries, like I was saying, where it's been for years and years and years. And now it's finally coming to the United States. The colors don't mean anything. So what happened was this company called Dental High Tech that started in France, New Smile built a relationship with them and started collaborating with them. And when they decided to bring on these devices, they've formed like another branch of New Smile called New Smile Tech. And if you've been exposed to the scanners or anything like that, those would be the things that would fall under the division of New Smile Tech versus the restorative materials. So that's the difference. So all of your dental materials, everything is, evolved. We've got nice chairs. They don't look like this anymore. But however, this is still what our syringes look like. I mean, you can buy a syringe at a flea market that's from the, early 1900s, and it will work. It will hold your carpal of anesthetic, and your needle will thread onto the end of it. So, again, this is something that we have not evolved at all in this. So how all this started was there was a dentist that lived in France, and this is where he lived, and his name was Alain Villette. And he really wanted to make his patients more comfortable. And he was just scratching his head, trying to figure it out, couldn't figure it out, tried all kinds of different things. And think about it, probably back in the day, you could try lots of different things and not have to, record stuff. You could, do things you can't do today. They'd be like against the law, or you get sued or something. So he tried all these different things, trying to figure out how to make patients comfortable and more profound anesthetic that was targeted to the teeth. And he finally figured it out. It was getting it through the bone and getting it to the apex of the tooth, so it just hit the nerve. And then his son became a dentist, and his son is still very active in the company, Olivier Villette. And they started developing these devices. The first device that he developed was called the injector, and then it became electronically controlled over there to the right, you can see. And in 1997, they developed Dental High Tech, and it was a small little company, and they developed what's known as the SleeperOne, and it delivered it electronically. So it, it held the cadence of the delivery of the anesthesia, and it was an intraosseous injection. By 2005, they'd come up with a proprietary needle that we're going to talk about a little bit later, but the needle is it's a big piece of the recipe here. It's a big piece of getting this right. Let's not spend all this money to get this nice device and then buy some needles off of Amazon. These are the needles that we need. And I'm going to show you why you want these Effitech proprietary needles as we move on. SleeperOne, it evolved into something that looks like this in 2007. By 2011, it's starting to get more streamlined, and it has a foot pedal at this point. This is pretty much what it looks like now, and this was in 2017, and this again was the SleeperOne. So now your dental devices don't have to look like something you buy at a flea market anymore. And this is a great picture to show. I think I have a few more pictures coming up, but these are the two devices that we are going to be talking about tonight, the SleeperOne and the Soan. The SleeperOne's at the top of the screen. And the two major differences are that the SleeperOne plugs in, has a cord, and the Soan sits in a charging station. So it is cordless, it is portable, you can move it from room to room. You can move the SleeperOne from room to room, but you have to unplug it. They both run off of a foot pedal. And the other second big difference that you'll see, this is a good photo to mention it on, is the SleeperOne, the lights communicate with you. They both have lights. We're not going to get into the weeds tonight about all these lights and the colors and how they blink and everything. But on the SleeperOne, the lights communicate with you all the way around. They go circumferential. So you can see the light no matter where you're standing, no matter what position the patient's in or where your hand is. Whereas with the Soan, the lights are on only one side of the device. So sometimes you have to cock your head around, or you have to ask your assistant, what they're seeing if you want to know what the lights are communicating to you. So where are you going to get one of these? Well, the only place you're going to get one of these is through New Smile, because they are sold direct. You don't get them from Atlanta Dental. You don't get them from Patterson. This is a proprietary product that New Smile has done all the, all the heavy lifting on, and these are the people that you're going to get in contact with to get these devices. New Smile has been around a really long time. They got into into dentistry, and then they just really found a vein in pediatric dentistry, which benefits all of us. But I just put this slide in here because when I started learning more about New Smile, I really didn't even realize how many products and things that they had. And I would say probably at the time I was using maybe half of the things just because I love them. And then I was like, oh my God, they make this too. Well, I'm going to start getting that as well. So I just put this slide on here to show you, like, these are all the things that they have, stepped up and been early adopters on to get these products and services into our hands. And I love the last part there. It says more to come, because there is really a lot more to come, and it's very, very exciting for our profession and our patients. Again, this is just a slide showing the two devices. I think Chris has said in the past, the Soan does weigh a little bit more than the SleeperOne, but I've held both in my hands, and it's not enough to me to tell a difference. I prefer the Soan. I know Dr. Lurie prefers the SleeperOne. She likes to see the light going all the way around. The reason I prefer the Soan is because I don't like cords. I have enough cords dripping all over my office. I don't want any cords. The other reason I don't want a cord is I always worry about a kid grabbing the cord when I'm using anything that has a cord on it. So when curing lights, you little children don't remember this, but curing lights used to have cords on them. They don't have that anymore, but we used to have to worry about that as well. But I do think if you look at these, they're so aesthetically pleasing. They do not look like a traditional syringe. You can use this on patients without having to, pretzel yourself around to hide the needle from them. And Dr. Lurie came up with the saying that she's just taking the patient's temperature. And that is truly what we tell patients now. We are taking their temperature. And then, you'll have that Flaco parent who's like, we're honest with our kids. We tell them everything. Okay. Don't get me started. All right. So again, this is just what they look like. While this slide is up here, I mentioned the needles earlier. I'm going to talk about them again, but if you see those needles right there, you see they have the letter D on them. I don't know why they chose a D, but D is a letter that was chosen. And it is important when you're giving the first injection that you have your eyes on that D. It's very important. And I'm going to show you where that needs to be in location to your patient when you're giving that first injection. Okay, so shut up, lady, and just please tell me how these things work. This is how manual delivery works, right? You're putting it in there. You think you're doing this jam up job and you're going nice and slow and whatever. And it is diffusing everywhere. Even though you have vasoconstrictor, even though you have epinephrine in there, it is going everywhere. You can see the mucosa change color and bubble up, depending on the site of delivery. Whereas when you're using an electronically controlled device, it's going at a set rate. The epinephrine can keep up and it can hold that in place, and it's not diffusing everywhere. So this is it, people. This is your first injection. You're going into the papilla. You're giving just a little bit of anesthetic just to numb the tissue. Literally, that's all you're doing. You're coming out and you're giving your second injection, and your second injection is a completely different angle. And this is the IO injection. This is the one that's going into the cancellous bone. You're going to punch through like that. And then you're going to put your foot on the pedal and you're going to start injecting. One thing I'm going to say before I go on is do not overthink this. People, they overthink it and they're like, I'm going to hit the root. I'm coming out the other side. These needles, y'all, are so tiny and short. You're going to do way more damage with whatever the longest size needle that you people like to use to give an infraalveolar injection in the back of the mouth, where Malamed says you can damage like 12 major things back there or something, right? So get out of your head. Just start practicing with it. Take it out of the box. First, give them your credit card, buy it, get it home, take it out of the box. Don't let it collect dust. And start practicing and playing with it. This is a very important slide to know and understand. When you give an injection with these devices in the maxilla, you can be confident that you're going to get profound anesthesia, 2 teeth back and 2 teeth forward. In the mandible, you can be confident that you're going to get profound anesthesia, 1 tooth distal and 2 teeth forward. Now let's think about that, right? This is showing this on an adult dentiform or cadaver, skeleton, whatever. Think about it. If we have a 4-year-old that has more porous bone, it's probably going to go further, right? We can probably get more bang for our buck, more, you know, it'll travel further in a younger patient than it will in your, 12 and 13-year-old kids that are, safeties on the football team or something. So just remember, in the maxilla, you're going to get anesthesia 2 teeth back and 2 teeth forward. In the mandible, you need to think 1 tooth back and 2 teeth forward. And the reason you got to think about this is you're treatment planning these cases, right? You got to think like, well, which papilla am I going in between? So again, this is showing like for the posterior mandible, you could go in between those 2 papilla. That'll take you 1 tooth back and 2 teeth forward. It is a 3-stage technique. The first one, if you remember back to that video we just showed, is an injection into the mucosa. It's tiny, it's little. You're stepping on the little part of the pedal, the middle part of the pedal, and you're delivering just a little bit of anesthetic into the mucosa. You're taking that out. You're letting your assistant rinse the mouth because you're going to get some anesthetic in there and it's not going to taste good. So they're going to rinse the mouth. Then you're coming back in at a different angle. You're going to punch through the bone. Once you're sure and confident that you're in the bone, then you're going to step on the big pedal and you're going to deliver the anesthetic for the IO injection. So it is really 3 steps. This is the first step. This is what it looks like. It's coming out extremely slow for that mucosal injection. Again, you're stepping on the middle portion of the pedal for this. This is the letter D that I mentioned. And you want it for the first injection, you want it facing out. And the reason that you want it facing out is these special awesome needles have a very special bevel on the end of them for how they penetrate the tissue. And if you don't have that in the right orientation, it will not feel good to your patient and it will not penetrate the tissue the way that you want it to. So this is just an example of that, the D pointing out. You're literally laying it into the tissue. You're not like poking the patient hardly really at all. And in my opinion, that's really like you could have been done probably 5 seconds ago. You really probably don't need to be in there that long. People want to know how long is that injection? 5 to 7 seconds would be what I would probably tell somebody. So again, there's your first injection. Your second part, we got to get through the bone and then we're going to deliver the anesthesia. So for this second part, the rate is much faster. When you're stepping on the outside of the pedal, the rate is going quicker. You're like, oh, that's going really fast. No, when you're watching the plunger, it still feels like it's taking an eternity to get this anesthesia into this patient. So this is going to show the second injection. Again, completely different angle. And we are definitely not going to sit here and watch how long that takes. So when I was trained on how to do this and Dr. Prin came to the office, the examples he gave me were that when you punch through that cancellous bone, it's going to feel like you're punching through an eggshell or potentially like a Capri Sun or a milk carton. And I will tell you that sometimes you do get that feeling. You do get that sensation. We, as dentists, we are very tactile. We can feel lots of things through our fingertips. And lots of times you will get that sensation. But there are times you won't. There are times it will just go ahead and penetrate right through the bone. You'll just hit it perfectly and you won't get that resistance and puncture. And this is not the litmus test that you are in bone. You'll know you're in bone when you don't see the needle anymore because it's in the bone. There's nowhere else it can really be but in the bone. So just don't let this trick you up. This is showing the anterior region. Yes, you can get all the way cuspid to cuspid in the anterior region in a primary dentition. And you can see the vasoconstriction right there. This is just showing it in the mandible again. You can get pretty far in a primary dentition. These are examples of showing that first injection, how you're gonna like lay it against the buccal mucosa to get in there, and you're gonna have the D facing out. And this is showing examples of the, angle you wanna be at when you're giving a mandibular injection or giving the maxillary injection. And I have some videos of this later. Thank you, Erin, for suggesting that. Again, you can see like we're straight up and down here giving this. We're going between these. She does not care. She's listening to Disney music. Doesn't even know what's going on. But see, that's a steep angle. And they're going, this doctor's going right between those two teeth. We're not hitting roots. We're not coming out the other side. And again, that is just really part of the learning curve. I love this video because I want you to watch just how cool and chill this little girl is. She doesn't care. You can see her little eyeball up under the glasses there. Not blinking, doesn't care. Another thing to observe in this video with Dr. Marina is she is very close to the patient. Like a lot of times when I think about my traditional anesthetic, I can kind of be like doing things out here using these devices. When I was training, and then we did some training with some other doctors in Budapest, is training people to, and that's, I think for us in peds, we're kind of used to being close to our patients and being up on them. We're doing behavior management, but in other countries, that's kind of you're invading someone's space. And we had to train other doctors and say, you have to be safe and to give the injection properly, you do have to be a lot closer to your patients. This is a patient in our practice. And again, this is just showing the first injection. We're just laying the needle sideways and getting into the tissue. Getting into the bone, giving that injection, and then literally take the needle out and extract all 4 teeth. Are radiographs important? Obviously, I wouldn't have this slide in here if they weren't. They're super important because we're giving an intraosseous injection. We're giving a injection into the bone is what that means. So if we don't have bone, we can't do these injections. So it's super important that we treatment plan properly. This is an example. I apologize for the clarity of the film, but you can pull out a pano and get a lot of great information. We know that we've got to get out those 2 baby teeth, and we know we've got to do some dentistry on that 6-year-old molar. So going right there, that's our sweet spot. That's where we have some bone. That's going to numb 1 tooth distal and 2 teeth mesial, and we can get everything done. You can literally give that injection. I'd probably give 3/4 of a carpule right there. I'd get out of there. I would fix the 6-year-old molar, whatever you're going to do to that. And then I would get out, my elevators and my forceps, and I would get out those 2 teeth and be done. This is another great example because, again, you can get tricked on a bite wing. I know this is adult teeth right here, and these devices are really for up to age, healthy, 12, 14. What's FD? What do y'all say?
13.
13 in between there. So recommended, confidently can use up to age 13. I will tell you in our practice, we only use these devices and we graduate kids when they're 19. It's me and 3 other doctors. I have nobody complaining to me that they can't get patients numb. That is not what New Smile recommends, but hey, we're pushing the borders over at Holly Tree Pediatric Dentistry, and we don't use traditional syringes. But this is a great example. You would think, oh, I don't have any bone between those two molars right there, but it's a 2D image, right? So pull out another image, pull out a pano, pull out a previous bite wing, and see if you have bone somewhere. And it's, you know, it's hiding from you from the angle of the x-ray. These are just examples of, you know, when you're seeking out good bone and you're trying to be strategic, that's a good place. You think here, I don't have anywhere to get those teeth out. Okay, so let's say that. Let's look at this middle film right here. Let's say you didn't have that good chunk of bone right where that canine is, and you've got to get out those two nasty teeth right there. The other thing you can do, you can use these devices like traditional syringes. You can go into the soft tissue. You can give a infiltration if you want with these devices. So you do have other options. It's not like you have to put this on the shelf and get out your traditional syringe. If you want to give an infraalveolar injection with these, have at it. If you want to give a palatal, have at it. Y'all are crazy, but if you want to do that, you can do it with these devices, which is the beauty of it, that you have, you know, different options and opportunities. Again, just finding sweet spots, finding good places to deliver into the bone. Just a few more, and showing you how numb it would get. Again, just showing examples of dentistry being done. Again, this is one tooth, this is one pulp and one crown, and it's showing that they used 3/4 of a carpule, it looks like down there. I probably would use maybe a half a carpule. I'm a little more conservative. But if I'm doing like an MO and a DO, I'm using a 1/4 carpule. And the other really cool thing about this, I really encourage you to let somebody numb you up. So you can see how it feels having the injection done. 2, seeing how it feels to be numb this way, because your face doesn't feel numb, but your teeth feel, they describe it as a woody feeling. And it is, when you tap them together, it's like this woody feeling. And then the other super cool thing is the numbness goes away immediately. It's not like it just starts to wear off. It's like literally 1 second you're numb and the next second you're not. Just showing some anterior beautiful dentistry here getting done. They looks about a half a carpule. Used a 1/4 carpule to get an MO and a DO done right there. I love this video. Dr. Felipe did this because this is what we would consider a hot tooth in our practice. You can see how infected this tooth is, and everybody worries about like getting palatal anesthesia. You're never going to have to give palatal anesthesia again if you're into that. You will get profound palatal anesthesia, and I want you to watch this because she's going to numb this kid and take some device and like go ripping on the palate here. And she's looked at an x-ray. She's made sure that she's found some good bone to get into. Second injection popped in. So now this is a good place to tell you. Now, when that happens to me, when I bury that thing to the hub, I bring it back about 1 millimeter. I want to see a little bit of that needle as I'm injecting. Okay, now we're just gonna rip this out here. Kid don't care. That just blows my mind right there. Literally, she didn't get up from the chair. She did all of that. This will also blow your mind. This is me. Megan numbed me, and then my husband put a crown on, and I had a temporary crown, and it had come off earlier in the day and was super sensitive. And I was like, okay, I got to get the real crown on because it's been like too long. So I knew it was going to be sensitive. So I knew I was like, they're going to have to numb it before I get it done. So Megan numbs me. Matt comes in, he rips the crown off. He goes with the handpiece to get all the extra glue off. And I literally felt nothing. I was numb. I could tap on my teeth all the way over to 10, and 10 felt weird. Again, I'm an adult, so Megan's having to work a little harder. She's trying to figure out, like she's twisting and she's turning, she's choked up on it really far. And you're gonna see it go in. When she gets it, there it went. And when that happened, I could like, I didn't hear it, but I could like feel it in my head, if that makes any sense. And I'm about to have it again. So I need another crown down here. Why is there minimal, if any, discomfort? Because we're using a special needle, and that's making it so we're not tearing into the tissue. We're delivering it at a cadence that is steady, so we're not spewing acid into the tissue. And we're using the correct ergonomics and support points and having a good strategy as we move along here. So this is what a standard needle looks like. If you look at it on SEM, it literally tears through the tissue. Whereas these proprietary needles, these Effitech needles, is what they're called. It's literally like a scalpel blade. And that's why you can just lay it on the tissue and it literally just like almost melts into the tissue to give that first injection. These are also sold by New Smile. You get, when we get to the end here, Chris and Jordan, you can say, and Aaron, how many you get when you get the device. I can't remember. Everyone gets hung up on this. How deep are you going? How far in are you? Well, you're going far in enough that when you step on the pedal, like anesthetic isn't flying out. You're just like right underneath the mucosa. Again, this is just showing what a manual injection would look like versus if you're using an electronic injection. I never gave an injection like this. This is something off the internet, obviously. But again, the ergonomics for delivering a traditional injection are not great. Whereas this, it is very intimate. It's very close up and personal. I feel much more in control using these devices. And I feel like the patients almost feel safer and more comforted as well. So final thoughts here, benefits and conclusions. The onset is immediate. So people are like, well, I need to leave the patient and go check recall. Fine, go leave the patient and go check recall. When you come back from checking the recall, the patient's still going to be numb. But what if you've already cleared the bay? What if you don't have any recalls? Or what if the kid's like B2 and, screaming their head off, whether you're touching them or not? Wouldn't it be nice to just go ahead and get that done instead of having to leave the room and the kid being there crying and anxious and upset? If you could just get it done. Like, I think about it, the first week I had a trauma patient, like a 2.5-year-old trauma patient. I had to extract anterior teeth. I don't want to leave that patient in that room, like bleeding all over and crying and all the things. Like, I just did it. I just got it done and got them out of there. So onset is immediate. One thing to talk about is we definitely want to be using articaine and septicaine here. We're not using lidocaine anymore. Pack your lidocaine up. This is for all of us who are, we trained on this. We should all know this, that when we are giving any type of injection into the bone, we want to use articaine because it has the chemistry makeup to the particles flow into the bone much better than they do with the chemical makeup of lidocaine. And we have two choices, 1 to 200 or 1 to 100. I really rarely work on a kid more than 30 minutes. We schedule ops for 30 minutes at a time. And if it's going to go over, I'm just going to give more of the 1 to 200. I don't want 1 to 200 and 1 to 100 and the assistant doesn't know which one and I have to look and see what got loaded. We just use 1 to 200 across the board. If you use 1 to 100, yes, you will get more working time, but there are studies that show that you can have a higher chance of an ischemic reaction. So for me, I use the extra short needles. I like everything simple. I want an extra short needle every single time. And I want the 1 to 200 in there every single time. So my assistants preloaded, we're ready to go. I don't have to second guess, what anesthetic or what size needle is on my devices. The 4 principles to be successful at this: use the most appropriate anesthetic solution, which we just talked about, inject the right quantity, right? Just like you would with a traditional syringe, like you're not giving 3 carpules of anesthetic for a DO on L, right? You're giving a quarter carpule. You want to think along those same lines when you're using these devices as well. Be gentle and take your time. These needles are going to bend on you if you're not gentle and you don't take your time. You have to be patient and you want to inject as close to the target as possible. I really don't want to get in this rabbit hole, but there's like this one study that just caught traction about, we shouldn't be using articaine and septicaine in kids under age 4. It really has been debunked through the years. We have lots of other great studies to support that articaine and septicaine are perfectly fine anesthetics for younger children. If you've ever sat in a Malamed lecture, he will go off on this. He will tell you the exact same thing. So what else am I not thinking about asking in this chat? Is there anything else like this on the market? There are things like it on the market, but there is nothing exactly like this on the market. We've got this thing that's floating around. People have seen this talked about on social media. This device is not recommended for intraosseous injections. There is no support behind this. The needles don't fit it. Like these are knockoffs. This is just not what you want. If you're on this webinar, these aren't the things that you want. Again, lots of other products. A lot of them do one thing or the other. They either deliver intraosseous or they deliver at a special cadence, but none of them do all the things that these devices do. What about hypoplastic 6s? The bomb. So good for hypoplastic 6s. I think this study, here's the study right here. If you're giving a local infiltration with traditional anesthetic, you're going to hit it about 25% of the time. If you're using intraosseous anesthesia of any type, you're going to hit it about 90% of the time. I walk into a room now, 19 occlusals on my schedule, no sweat. I got it. Because 19 occlusal could be like a pit. You don't have to numb at all. Or 19 occlusal can be some bombed out hypoplastic disaster. And you're not having to give like 3 injections and sitting and waiting and like, are they numb yet? And then you bring them back because they weren't numb. So, I mean, this is just, you're going to hit it every single time. Topical. Do you need to use topical? You do not need to use topical. The kids rarely are going to feel that first needle get embedded. However, I choose to use topical because I want to use it as a litmus test for the child's behavior. So do I need to even put anything on it? Probably not. I could probably just put a dry Q-tip in their mouth, but I want this to be my test to see how crazy are they going to act. And I want their parents standing at the window to see they're acting crazy with a Q-tip in their mouth right now. Like we're all going to watch together how this goes. What size needle? Again, they come in different sizes. I really like the extra short. How much anesthetic should you give? You're going to be strategic about it. What's the size of your patient? What's the age of your patient? How much dental work do you need to get done on this patient? And what type of dental work are you doing on this patient, right? These are all things you have to take into account when you're treatment planning a case, just like you would using traditional anesthesia. And how much time are you going to need to get this done? I love giving palatals. Do I still need to do those? You're crazy if you like giving palatal. I don't think I ever gave one ever. I always got patients numb, creative ways otherwise, but no, these drive people crazy. You don't have to give palatals anymore. The palatal tissue, you can place a rubber dam right away. You can poke around on the lingual. You're going to be totally fine. So the learning curve, I would encourage everybody to start in the primary dentition. Don't do it on a bigger kid that has more ossified bone. Do it in a primary dentition on a good behaved kid. You're going to bend some needles. So maybe practice, if you've taken any of the hands-on courses, New Smile brings pig jaws along. So practice on, I don't know, on a, not pig jaws, chicken bones, practice on a chicken bone, practice on something, before you start wasting a bunch of needles or, poking on your patients too much. Breaking needles, it doesn't happen. I think they've got one case report at New Smile of a broken needle, and the doctor, full disclosure, was like completely over executed what he was doing with the device. So breaking needles does not happen. You're not gonna have needle separations. You're gonna have bent needles. The needle where you're going to have the weakest part is the needle's going to bend. And then, picking your injection sites. Try to pick injection sites that are more close to the anterior, so you're not having to be back in the back of the mouth and control that at the same time. And then getting a good grip on the device. When I'm training people, I see people want to be way far back on it. And just like when we're training our assistants to hold that HVE, we tell them, like, you need to choke up on that thing. You got to be like super close down to it so you have more control over it. Same thing with these devices. The closer you can choke up on it and have a good grip on it, the more you're going to feel in your fingers when that needle is about to bend on you. Just some examples of giving you anesthetic. That's that first injection. And see how they're choked up on it and they're twisting it, right? They're trying to give it some help getting into the tissue. Being super patient. And they're in. So I put these in. I haven't even watched these. These are going to be so cringy, I'm pretty sure. But there's been some people who have expressed wanting to know, like, where do you sit? How do you sit with these patients per quadrant? So I have 4 very, very short videos showing you by quadrant where I would recommend sitting and what angle I would recommend giving the intraosseous injection. The important thing is like to get the patient in the position that is beneficial to you. So for this upper right side, I'm very close to my patient. I've got my elbows tucked in. I'm very close to my patient. So this would be for the upper right quadrant. And then for giving the injection, this is for part 2 of the injection. I'm going to go in like this. I'm going to go in like this. Go in like this. Good. People say they really struggle with the upper left, and you've got to remember that you can move your patient. So I'll have my patient move to me like this. And again, I'm sitting very close to my patient. I'm not like way up here with my arms. I'm very close and have my patient in close. And then I'm holding the cheek back and retracting, and same angle. I would go in like this. I could go in like this. I could go in like this. I think that's a big thing right there. We are not in the habit of moving our patients around because we also have the nitrous nose on them, right? And we're like, oh my God, I got to move everything. But get in that habit. Get the patient in the position that is the most ideal for you, because that's going to be the most ideal for them. To the lower left side now, depending on, you know, you've got 2 options. You can either come in like this, stay on this left side, or you can roll around past 12 o'clock and come like this on this side, like this. It's really what your comfort level is. I like to stay on this side. My assistant's over here suctioning, so I try to stay on this side and just get a really high angle. So like this, or like this. Is usually the easiest quadrant if you're just getting a Soan. This would be the quadrant I would want to start practicing in. Is this is where we normally sit anyways when we work, and you're just holding the lip out, and again this, and this. So I hope that's helpful to people to see the angulations on that, and kind of like where you should sit, and you are all gussied up on that patient. So remind me again why I need this. Immediate onset of anesthesia, predictable anesthesia. Remember, if you bought it for nothing else than to use on hypoplastic 6s, you should buy it. No delay between delivery time and being able to work on the patient. Way less stressful for everybody involved. No post-op side effects or phone calls from families. You can optimize the appointment, right? You can get more dentistry done. You can stay in the room and work, or you can choose to go check recalls or the scores, whatever. And then if you don't market the hell out of this, shame on you, because this is something that, you know, patients come in and they're like, why doesn't my dentist have this, right? Like all the adults want their dentist to get this as well. So, you know, really market this, use this to your advantage every way that you can. And just remember, you're never going to have to give another inferior alveolar injection. Right? That's how they feel. That's how we feel. So what do they cost? I've got them both pulled up right here for you. The cordless one, the Soan is $29.50. The sleeper is $2,700. If you buy more than one, you can see that there is a price break available there to you. Aaron, Chris, and Jordan are your people to talk to you about this. If you're interested in getting 3 or more, right? And I will tell you, I bought 2 right out the gate. I have 2 treatment rooms. I bought 2 right out the gate. I lecture for New Smile, but I am a doctor. I paid full price for both of my units. I'm adding on to our building. I just have purchased, I'm buying 2 more for the next 2 treatment rooms. I will not be moving these devices around. I'm not going to have us playing that game. I have them in every single room. So how am I going to learn to use it? We have lots of great support for you for that. This is Chris. He started us off tonight. This is all of his information. And we have Jordan, who has joined us on the call as well tonight. This is Jordan's information. So you can get in touch with both of these gentlemen, extremely accessible. You can text them, you can call them, you can email them. And then we've also got Erin on the call, and Erin is a huge asset at New Smile as well. She can help you. She really knows a lot about the devices. If you run into anything where you don't understand something or the settings get off, I mean, they're all great, but I mean, you can rely on all these people tonight. You know, they've got lots better things probably to do on a Wednesday night, and they're all on this call tonight to help you and be there for you. So how else are you going to learn to use it? Dr. Andrew Prynne, he's a huge voice for us. He's one of the trainers from the UK, and he is who came to our office and trained us. You can get study clubs together. You can reach out to Chris and Jordan and Aaron, and they can help you. If you have a study club, they can do Zooms for you. If you're close by, they can maybe do something in person if they're going to be in the area, which is what we did. This is my community. Almost everybody has one now. Playing around with them. And then this is just one of the greatest things right here. Definitely scan that code or take a picture of this and go join the group. You do not have to own the devices to be in this Facebook group. This is a great place to learn. It's a safe space. If you're having trouble with the devices or have questions or want to post a case, I mean, this is the place to do it. I go in there every single day and learn, try to help somebody, but I also try to learn something in this group as well. So who else is using these devices? A lot of you know Dr. Bobby Elliott. Not an early adopter. Takes a lot to get this guy to move off and budge on things. And I finally got him to get it. He said, it's working overtime like a boss. I took out an upper right fore and a 13-year-old and then some canines. Easy peasy. I'm pumped and parents are blown away. Thank you both for all your excellent education and tips. Lori said, great job. And we just said, you know, keep stories like this coming, because this is what pumps us up and wants us to get it in more people's hands. Dr. Brian Richards, he's a big one on IPEDO. His first case was a trauma case. Kid was super sensitive on the lower anteriors. He used a half a carpule and the kid never felt anything. Thanks, Ian, for selling me on this. I'll be curious to see how tomorrow's appointments go. So the next day he used it. He did quadrant dentistry. He's a rubber dam user, placed rubber dams, pulps and crowns, all the things. Huge advocate now.
And I was
yeah.
just going to chime in about Bobby real quick. So I'm in Atlanta with him right now.
Right.
I walk into the hotel lobby right after I check in, and he's talking to a couple other doctors. As I walk up, he's talking about the Soan, and I was cracking up because I was like, I'm jumping on a call right now about it.
Yes. And again, you just got certain friends who are like, oh, I'm going to wait till like 100 people get it and then I'm going to get it. And I was like, no, you're going to wait till like 5 people get it and then you're going to get it because you need to get this. So same thing with Dr. Meredith. She's a dear friend. She's here in South Carolina with me. She was super hesitant. And even after she bought it, she left it in the box too long. She finally took it out. And this is the text I got. I did it. I numbed at 10:13. I was done extracting E and F at 10:15. He did not move. I said, can I please put this in my webinar tonight? We are all so proud of you. And this is the chill bumper for me. It was a huge rush. Like, yay, dentistry can be fun and new and exciting again. And when you've been doing it a long time, it does get monotonous. I mean, that's why New Smile just did a whole series on burnout, right? At Bourbon and Baby Teeth this year, because it is a grind. It is a total grind. And when you have a product like this that can make things better for our patients. Chris is crying right now about it. Chris. Swiping his eyes. Anyways, it really has made dentistry fun again. Especially talking to parents about it. They're like blown away. They don't understand it. So anyways, thank you guys so much for tonight, for listening and staying up late when you have other things to do. Really appreciate you. This is my QR code. If I can help in any way with anything, dentistry, New Smile products, the Soan, frenectomies, how to, have a great culture, anything. I want to help you be the best that you can be any way that I can. This is how you can reach out to me. This is my QR Popple code right there. And that's all she wrote, people. Any questions, Chris?
All righty. We have one question. Your video has been very popular lately. So, of your treatment, of you getting it done. So the question is around your experience. They just want to know, for your crown, what length needle was used? Did you use
Extra short.
the green 9mm?
Yes, extra short. And my husband, who is a rogue person as well, when I got these devices, he loved them and he was taking them over to, we're in the same building, obviously, and he was taking them over to his side and using them. And he doesn't anymore because we need them. We have 2 doctors running them at all times every 30 minutes. But one example I can use is John's college roommate was at a frat party and fell on his face and knocked out a Maryland bridge and needed it put back in so he didn't look like a homeless person. And so drove from Clemson, came down the next day. It was on a Saturday. Matt's like, oh, I want to use it. So he used it on him, numbed him up because he had to re-prep the teeth to get a better situation for this Maryland bridge that was going on. So, I mean, can you push the envelope and use it on adults? You can, but I don't know if you're going to have the same confidence level that I as a general dentist, I would not recommend purchasing it and marketing it and using it on all your patients because it's going to be hit and miss. But, in special situations like myself, like when I get this crown done on 18, I'm going to have one of my doctors numb me. I'm going to record it and let Matt prep that tooth for me.
Can you talk about the different settings for injecting the medicine? Do patients report discomfort on the high setting? If they do, how can you alter your delivery? Great question.
Great question. So the foot pedal has the inside pedal and the outside pedal. The inside pedal is for the mucosal injection, and that goes very, very slow. I can't think of the last kid that felt that when I did it. And then for the outside pedal, that's delivering it at a very slow speed. And Chris, you can maybe talk on this, that there are different settings inside of that once you get past, past a quarter carpial, you can tell the device to speed up and start delivering faster, correct?
Yeah, so there's a ramp up period that it does ramp up the speed of the delivery. But there's also 2 different delivery modes. There's a low and a high. For the Soan, there's 3 modes on the SleeperOne, but those delivery modes are relevant to specific injection types. So if you are giving an intraosseous injection, if you're doing true IO, you're always going to be in that low setting, which is the blue color. And that is, again, specifically designed to deliver that solution at the appropriate speed. So there's no discomfort.
Right. Once I'm in the bone and my foot's on that pedal, there's no someone jumping up or feeling something like that. Just doesn't happen.
Yeah. Next question is, how do I know if I am in the PDL when the Soan shows 2 to 3 blue dots?
I'm not sure how you would ever know when you're in the PDL because I don't know what the PDL feels like when you're in it. But if you have your syringe at the right angle, you're going to be in cancellous bone. You're not going to be wedged up against the PDL. When you're getting those dots that go up, it sounds like you maybe have a device or a good bit about it. But on the Soan, there's 4 dots that are on there, and they climb. They get more dots light up as you get more back pressure in the device. If you're getting back pressure in the device, if you're getting those lights to light up, I highly doubt that is because you're bumped against a PDL. I would say that's more that you either have a spicule of bone stuck somewhere in the needle that is causing back pressure, or you've got a bend in the needle, or you are literally nudged up against bone and fluid can't flow out. So in those cases, when you do, it really doesn't, if you see those dots go up, it really doesn't matter which of those situations you have going on. Your protocol will be the same. Your protocol will be to back up a little bit and see if you can get those blue dots to go away. If you can't get the blue dots to go, if you try to reposition, don't come all the way out and go back in, but just back up a little bit and see if you can get it to flow and get the dots to go away or go down to 1 or 2 dots. And if you can't, then I would come all the way out. I put a new needle on and I would go back in, because something malicious is stopping the flow of the anesthetic at that point.
The other thing I'd add to that too is, you know, 2 to 3 blinking lights on that pressure indicator. The unit is going to automatically adjust as well. So it has the sensors in there. It has that plunger with all the brains and the algorithms in it that are sensing that resistance. So it'll actually back up on its own and deliver that solution a little bit slower to let that diffusion happen. If it does jump up, like Dr. Bynum said, if it does jump up to 4 lights instantaneously, most likely you have a clogged needle. That's typically what happens.
And I don't just see 3 blinking lights and go, oh my God, I gotta, I'll watch it for a while. I'll watch it blink a little bit. And if it go, you know, sometimes it'll go back down, like you said, Chris. And then I'm like, okay, it's totally fine. It's going.
Right. One more question. Do you have any recommendations for optimal location for the intraosseous injection site? For younger patients, do you find the insertion point to be slightly higher towards the teeth or lower?
I go in the same place for everybody. Just like I showed in the videos.
Mm-hmm.
I've seen some people go a little steeper, go less steeper. I like to go steep. I feel like the if you watch that first, you know, cartoon video that was made, that the peak of that bone, the height of that bone is where it's the most cancellous. And that's what I'm aiming for. And then I'm just staying, if these are the roots of the 2 teeth, if this is one tooth and this is another tooth, I'm going to go just like this. I'm not going this way. I'm not going that way. I'm not going this way. I use those as like my guides for what I'm doing.
Yeah, absolutely. Another question is, you said it's not very heavy. Do you have any estimates of the actual weight? Just curious.
Well, Chris knows particularly.
Oh,
The actual weights. Go ahead, Jordan.
Yeah, Hamed just taught me this. It's 87 grams for the Soan compared to 67 grams for the SleeperOne. So 20-gram difference.
I would say, Dr. Bynum, I would say it's, from a weight standpoint, it's probably pretty similar to holding a handpiece in your hand, something like that.
I feel like a handpiece weighs more, but I've also got like a motor coupler on mine and all these things to make them
Gotcha.
jimmy into my units. But I don't know. I feel like they're super light.
He said, awesome. That's the nerdy answer I wanted. You're welcome.
The grams.
Good job, Jordan.